Welcome on this podcast on how to understand and to deal with tendinous problems. For this specific podcast, I have been inspired very much by the valuable work of Professor Jill Cook, Ebony Rio, and other colleagues who are really authorities on the scientific background and treatment strategy of tendinopathy. So if one day you have the opportunity to attend some live course with them or to read their publications, I strongly recommend you do so. Well, during this podcast, I'm going to focus on some important theoretical considerations in combination with a lot of practical examples. And for your convenience, I also provide a PDF file of this presentation. Well, first, we need to understand something about the bioplasticity of the tendon. Actually, the pathogenesis of tendon pathology is from the cell. And what do I mean by that? Well, cell changes precede any changes to collagen in pathological tendons. And we have to realize that tendons are relatively avascular and aneural. The blood supply is variable and influenced by exercise and muscle contraction. And of course, later we're going to see that when we talk about treatment of tendinopathy, movement is going to be super important. But then there's also something strange. The tendons in the upper extremity and the lower extremity, they seem to be structurally different. The peritendon, on the other hand, is richly innervated and supplied with blood vessels. There are some kind of free nerve endings which send information about changes in the tendon, and that's interesting to know. About normal tendon function, well, we have to realize that larger tendons, such as the Achilles tendon, they can withstand more load. Longer tendons, also Achilles, they can store more energy. And in literature we talk about tensile stress and tensile strain. Well, just to define those topics, what exactly is tensile stress? Well, the tensile stress is calculated by dividing the load placed on a tendon by the cross-sectional area. So, the larger the cross-sectional area is, the more load can be dispersed, so there's less stress on the tendon. The tensile strain, well, how much can the tendon elongate compared to its unloaded length? As I mentioned before, there seems to be a difference between upper and lower extremity tendons. There's a difference in function, but most likely also a difference in treatment strategy. So the tendon function is related to its composition. More specifically, energy storage tendons, such as the Achilles, they seem to act more like a spring. A supraspinatus, on the other hand, is more a positional tendon. And long tendons in the hand, they need actually a better gliding function. But what is more important, actually what is super important for us to know about tendinopathy, is more specifically the different loads which act on a tendon. And the first load we're going to describe is the tensile load. And what is the tensile load? Well, the tendon stores and releases energy just like a spring by movements that involve some velocity. As an example, Achilles tendon, patellar tendon, during running, jumping, a tennis game. So this kind of load is very provocative for tendons. On the other hand, there's also a compressive load. And what does that mean? There seems to be some pressure against the bone. For instance, compression of the Achilles tendon on bone during an extreme dorsiflexion. So in that case, well, heel raises might be useful because in this way we can avoid this type of compression. Also interesting to realize is that long tendons are resilient to energy storage overuse. and short tendons are more vulnerable at their insertion. And that's something we see so often in the shoulder. Yeah? For instance, supraspinatus, infraspinatus, subscapularis. If there's a problem over there, mostly it is at the insertion. Which other load do we have? For instance, a friction or a shearing load. In that case, we talk about low loads in repetitive movements, whereby there's a shearing of the outside layer of the tendon against the tendon. For instance, repeated plantar and dorsiflexion movements during cycling in the Achilles tendon, or during swimming. And that can cause what we call a paratendinitis or a tenosynovitis. One thing which is also interesting to know is that in that case the peritendon structure may change because of those friction or shearing loads. For instance, the cyclist. During cycling, there is no significant energy storage load on the Achilles tendon. But let's imagine there is a poor bike setup. So the bike is not adapted, or the position is not adapted for this particular person. Or there is an unadapted cycling technique. For instance, heel off the back of the pedal, repeatedly falling into dorsiflexion. Well, that could cause more friction, shearing load, and perhaps also more compressive load. So keep that in mind. And that brings us to the next load, the mixed load, a combination of tensile and compressive load. We see that, for instance, in a fast energy storage movement while someone is in a compressed position. And the perfect example is, for instance, a sprinter in his starting position when he's pushing off from a dorsiflexion position, and then, wow, there he goes. Well, in that moment, there could be a mixed load. What are now the consequences of understanding loading? Well, certain tendinopathies, they can occur at every age, and some others not. For instance, for an Achilles tendon, there doesn't seem to be an age limit to get problems. Yeah. You can have young athletes, specifically during running and jumping, but older and more sedentary people, they also can have an Achilles problem, because the tendon still acts as a spring, remember, when those people are walking. Patellar tendon problems, on the other hand, are more frequently seen in younger people. They can bear high loads because of quick jumps and direction changes during certain sporting activities. But then an important conclusion is the following one. If fast energy storage loads are provocative, and then we're going to set a treatment plan, well, start the treatment with static or slow loads. What about pathological changes in the tendon? Well, we all know there is an overuse of medical imaging in the musculoskeletal field, not only when it comes to back pain, but certainly also when it comes to tendinous and muscular problems. But we have to realize that pathology does not equal pain. Mostly there is no link between structural changes we observe, for instance, collagen tearing, degeneration of collagen fibers, neovascularization. There's no link between this and the patient's symptoms. Most common element of tendon pathology is collagen matrix disorganization. And this is seen only in an isolated segment of the tendon. And this is important because this isolated segment of the tendon where you see this collagen matrix disorganization, has diminished load-bearing capacity and becomes so-called mechanically silent. So it becomes less functional. Why is a tendon vulnerable to pathology? Well, mostly because of load accumulation throughout life. But the problem is we don't know how much load accumulation is good or not good. But what about inflammation? Yeah, many people also receive non-steroid anti-inflammatory drugs for their tendinitis. But the question is that useful? Well, the answer is mostly not. Yes, inflammation is observed in pathological tendons, but it could also be a normal response to loading, because a mechanical stimulus may result in elevated inflammatory cytokines. So the role of inflammatory processes in the pathogenesis and or symptom development is at present time not confirmed. So anti-inflammatory treatment, well, is not considered to be very efficient. But I would like to make one little side remark. The use of non-steroid anti-inflammatory drugs temporarily, short-term, could be interesting in case of a rare occasion of acute tendinitis. Well, there are 3 stages of pathology, and the first stage is the reactive tendinopathy. And what is the reactive tendinopathy? Well, this is a short-term response to an overloading stimulus which causes a hypercellular response and adaptive tendon thickening. And this adaptive tendon thickening, this is an interesting mechanism of nature to reduce the stress on the tendon. We see intact collagen and fibers, possibly some swelling is visible on medical imaging, but the swelling is there not because of inflammation, but because of cells that attracted water. And the good news is that despite the cellular reaction, the tendon may return to normal function or to normal structure if the overloading stimulus is removed. So in fact, that's quite good news. So we see that generally in younger people. And when do we see that? When the patient is exposed to unaccustomed exercise, for instance, or commencing a type of exercise after a period of rest, for instance, after trauma, yeah, or when there's a direct blow to the tendon. The second stage of pathology is the tendon disrepair. If the original reactive response is not settled, fibrillary disorganization begins. So the matrix disorganization remains localized. You get a kind of mechanism of failed healing, but rarely this is associated with symptoms. And that brings me to the third stage, and the third stage is the degenerative pathology. And this pathology is really irreversible. As you know, there are some areas of pathology which become mechanically silent and they do not transmit load anymore. And we talk about a smaller section of the tendon. And vascularity is a good marker of tendon degeneration, which you could see on medical imaging. But the good news is the tendon adapted to this and is still capable of taking large amounts of load, despite those smaller sections of the tendon which are pathological. We see this more often in someone who has a long history of tendon loading. But most commonly, in fact, we see a mixed presentation of the reactive stage and the degenerative stage. And this is a patient who gives you a history of intermittent tendon pain, but already present during years. And indeed, on medical imaging, we see a degenerative area. We see a malalignment of collagen fibers, but, important to know, lots of load-bearing tendon around that area. So, this kind of situation where you have a combination of reactive phase and degenerative phase, in fact, is an overload of the remaining normal part of the tendon. And that's interesting to realize. And as we know, tendons are capable of adaptation. We really can observe load-appropriate changes. For instance, in patellar and Achilles tendons, there's an increase in their cross-sectional area to compensate the areas of disorganization. And of course, this is an interesting natural mechanism, because in this way the tendon stress is reduced. On the other hand, this doesn't happen in a supraspinatus tendon. A supraspinatus tendon does not seem to get thicker with pathology. Yeah, you see here again a difference between upper and lower extremity. Of course, we have to look at things from a bigger perspective, because tendinopathy can also result in a maladaptation in the remaining kinetic chain. You get poorer strength in the associated muscle tendon unit. You get poorer strength in the capacity of the whole kinetic chain, and less ability to function as a spring. Yeah, remember, that was an important function of a tendon. Keep in mind, tendon pain is localized and load-related, but persistent. And the brain and the spinal cord, they are aware of this persistent pain condition. And there is some evidence from motor and sensory changes in a number of tendons, including, for instance, lateral elbow, the tennis elbow problems and rotator cuff problems. So that's also interesting to realize. So when we talk about the relation between pain and pathology, well, then it is clear now for us that just pain interventions will not be efficient, because they don't address dysfunctions such as motor inhibition, strength and power deficits, or tendon load capacity. So intervention that target structure, they may improve tendon structure. Yeah, so sometimes it is useful in certain situations to do a kind of specific treatment on a specific area in a tendon. Yeah, but therefore, of course, you also need a good clinical reasoning and a good diagnostic path. But keep in mind that the intervention, let's say, to target the structure that will not address functional deficits or load capacity, and it may leave the tendon vulnerable to re-injury. So there's always a chance you have some recurrences. So keep that in mind. Again, from the point of treatment, we have to look at the broad picture. Tendon pain is well localized and very well related to load. Let that be very clear. It actually has a very on-off pattern with load. So load, pain, no load, no pain. In fact, we actually do not know what exactly drives nociception in tendinopathy. Unfortunately. Is pain something good or something bad? Well, it's also nice to realize that pain is not necessarily equal to harm. Some pain during rehabilitation is perfectly acceptable. And we also have to realize that unloading a tendon can be as unfavorable for this tendon as overloading the tendon. Yeah? It works both ways. And that brings us to the capacity of the tendon. And what is the capacity? Well, a tissue is at full capacity when the individual is able to perform functional movements at the volume and the frequency required without provoking symptoms or causing tissue injury. Important for us to realize is the following aspect. If you decrease the load, automatically the tissue capacity will decrease. If you increase the load, automatically the tissue capacity will increase. Use it or lose it. Actually, that's the key element. Yeah? Use the tendon or lose the tendon. And the good news is that capacity can change within weeks of unloading and also perhaps within weeks of reloading. That's interesting to know. If a tendon is unloaded, it loses its mechanical capacity already after 2 to 3 weeks. So that's really important to realize, because if you see a patient who had a fracture, and of course because of this fracture he's not that active as he was before, we have to realize that this has consequences in his tendons. So when we think of, or when we are revalidating this patient, progressive loading is going to be super important. Yeah? I repeat that again, progressive loading is important. But okay, how can we measure the capacity of the tendon? Well, through dynamometry, we can measure certain aspects. We can measure the strength and the endurance. But measuring tendon capacity, this is something which doesn't seem to be so easy. Even extensively pathological tendons appear to have the capacity to tolerate very high sporting loads. This is also something to consider. It's very important that we collect some crucial information from the specific history of the patient. We have to realize that if the patient describes pain at night, that this is not related with tendon pain. Pain in the morning, or let's say first movement pain, this is often related with tendons. One of the questions in the history, of course, is, okay, how can you influence your pain? Yeah, what can you do to make it worse or to make it better? So let's try to find out which load or which loads are dominant in the story. Then we can work with that. Was there any kind of injury? Or is the patient describing pain after having done a load exercise that is not so usual for him? For instance, a recreational athlete who is training for a marathon. Or perhaps is there any change of the way in which they run? Or a change of the shoes or the track surface? Or an excessive duration of a training session? All those things we really need to explore. A very important question is the next one. Tell me, if you do more exercise, do you feel worse the next day? Well, mostly tendon pain will get better and better as you do an activity. Could be more sore at the end of the activity, and in exceptional acute situations, indeed, during activity, it can get worse and worse, and the patient has to stop his activity. But mostly the next day, it will be substantially worse. And this is a key element in the history. For instance, the patient can say, if I run 5 kilometers, I have morning stiffness that lasts about 10 minutes. If I run 10 kilometers, I have morning stiffness that lasts 15 minutes, for instance. Another thing to check is, did the patient had some kind of injury before, within, let's say, the last 3 to 12 months? For instance, he had a knee or an ankle sprain, and because of this problem the patient was unloading the tendon for a certain time, and we know in the meantime what happens when you unload the tendon for a certain time. The tendon's capacity decreases, and then the patient returns to training, which implies he has an increased load. So there's something could go wrong, if he returns to activity too fast or too heavily. As I mentioned before, check the shoes, check the surface on which the patient is running, perhaps the change of orthotics. Body weight is also an important element, because visceral fat seems to be very pro-inflammatory. It seems to drive a lot of systemic and inflammatory changes in the body. Cholesterol can also deposit in the tendons, and diabetes patients, they seem to have 3 times more risk to get a tendinopathy, because diabetes also can stiffen the tendon. So keep that in mind. And then there are some risk factors we can't change, such as genetic factors, people with an autoimmune disease. But those people, they frequently describe problems, intermittent problems, at the tenoperiosteal junctions. You see that a lot in the shoulder. You see that also Achilles and the elbow. And they also describe more than 30 minutes of morning stiffness. After the menopause, or using certain kind of antibiotics, that could also be a risk factor for certain tendinous problems. When we talk about tendon healing, we all know we have 3 different phases. The inflammatory phase, which takes about maximum 2 weeks. The repair phase takes about 2 to 6 weeks, and the remodeling phase starts at 4 to 6 weeks until 12 to 16 weeks. And of course, in those phases, movement is going to be crucial. Movement and loading. In order to diagnose a tendinous problem, we have to keep in mind some important key elements. First key element is that the symptoms must be related to overload. Secondly, we talk about localized pain. There is also a load-dependent increase in pain. And symptoms get worse the day after higher loads. And finally, we keep in mind that palpation and imaging don't have a real diagnostic value. More specifically, when we talk about Achilles tendon, the patient is going to describe localized pain, load-dependent pain, and some morning stiffness and pain up to 30 minutes perhaps, maximum. Of course, functional testing of the Achilles tendon will also be positive. When we talk about the patella tendon, then we have to make a differential diagnosis with patellofemoral pain. And in the case of patellofemoral pain, well, patient is going to describe some more complaints during a sit position or sitting position, for instance, a longer drive in the car or sitting in the cinema, whatever. They cannot sit longer than 10-20 minutes. They have to get out, they have to stand up, and they have to straighten the knee. That's typical for patellofemoral complaints. But when you talk about a patellar tendon, well, they really hate the stairs. It is load-related local pain, again. And more specifically in the morning or the day after some activity. Always the same clinical pearls are coming back. And of course, don't forget also the functional testing. When we talk about hamstring tendons, well, they don't like to sit on a hard chair. They don't like to sit too long. Gluteus medius tendon pathology is seen in elderly postmenopausal women. They describe some pain at night, sleeping on either side. Perhaps they wake up because of this. But remember, at the beginning of this podcast, I said that pain at night doesn't make us think of a tendinopathy. So, to be honest, we have to make sure we make a good differential diagnosis. Personally, I think that a real symptomatic gluteus medius tendinous problem is really not frequent. But on the other hand, that those people are more likely to suffer from a bursitis. And a good functional examination is going to help you to come to this differential diagnosis. And of course, also those people, they can describe some symptoms on going up and downstairs. Perhaps one little remark about resisted testing. Well, by definition, something that is slow or static is difficult to deal for a tendon. It can be very heavy, it can be very hard for the muscle belly, but in fact it's not that hard for the tendon. Another little side remark about resisted testing. Sometimes in your functional examination it is really necessary to do repetitive testing, repetitive resisted testing, increasing the load, because it happens very often that one single test is negative because the load we put on the tendon is not big enough to test it in an, let's say, efficient way. Okay, to conclude this session on tendinopathy, I would like to give you a rehabilitation progression for patellar tendinopathy. So a real, let's say, scenario for what can we do with a patient who is suffering from patellar tendinopathy. Well, there are different phases. And the first phase is the phase of pain management. So it's our purpose to reduce the pain. So what are we going to do? We're going to do isometric exercises in mid-range, as good as it can be tolerated by the patient. Reduce the loading and some activity modification. Which exercise can you do? For instance, sustained holds on leg extension, about 45 seconds, 4 repetitions, twice a day, for instance. The second phase, we go for strength progression. You can do some exercises to improve the strength. You do functional strengthening. You do power increase exercises. And therefore, of course, there are quite a lot of different options which you can have a look at in the PDF file of this podcast. And in the third phase, we're going to do energy storage. We're going to develop stretch, shorten cycle training, more sport specific. For instance, plyometric exercises, graded exercises, certain drills specific to sport, including endurance training. And that brings us to phase number 4, the phase of maintenance, so management of the symptoms and prevention. Education, continuation of strength training, and manage the loading as tolerated. So in general, when you apply those 4 different phases, okay, we can achieve nice results. But the very important key element is what we call the 24 hours response. The most important time to listen to a tendon is 24 hours after you have put a load on it, because that is when it will tell you whether the tendon is happy or not. Again, I refer to another part in this podcast, the important question in the history, remember, what happens the next day? You are loading the tendon today, but what happens the next day? Do you have some after symptoms the next day, and how long do they last? And to conclude, some general remarks. safe loads are static and slow. So, in other words, isometric and isotonic. Important, keep that in mind. Safe loads are static and slow. We already know that pathology on imaging is not so important. Yeah, you can have a lot of false positive medical imaging. You see changes on medical imaging, but the person doesn't have any problems whatsoever. Yeah? On the other hand, if you have a tendon scanning and it's completely normal on imaging, you can be relatively sure that the tendon is not the source of the pain. And another little detail, it does not matter how much vascularity you have in your tendon. It does not tell us whether you're going to get better or not. No, that's irrelevant. This vascularization is just mainly a marker of, let's say, the degree of degeneration. There's also a higher risk for tendinous problems in the peri and post-puberty phase. We keep in mind that orthotics could be useful in children, but not so useful in adults. And keep in mind something we also discussed during this session, morning stiffness and pain that last more than 30 minutes. First thing you think of is some inflammatory component. So, that's all for this podcast on tendinopathy. But the most important lesson, very important in musculoskeletal medicine, make sure you respect clinical reasoning procedures, you focus on the important elements of the history, and at all times you perform a reliable functional examination. So, have fun and talk to you next time. Bye-bye.